Go ahead and just get started. So thank you, everybody. Good afternoon and welcome to our second Global Clinical Care Alliance webinar. My name is Kate Douglas, and I'm an Associate Professor of Emergency Medicine and Global Health here at GW. And I'm one of the founding members of the GCCA, along with Dr. Gail Rousseau. I'm really excited to be hosting this webinar today. Excuse me. And first and foremost, I'd like to take a minute to thank Dean Bass for her support of the GCCA initiative and her overall support for global health here at GW. We wouldn't be here if it weren't for your support, so thank you, Dean Bass. So on behalf of our full panel of presenters here today, I am really happy to introduce this group and this webinar. The title today is Global Acute and Emergency Care Systems Development, Lessons from Around the Globe. One small housekeeping item is if you have any questions as we go along, we have the chat function enabled. We are going to have some time for discussion and Q&A at the end. And so anything that comes up along the way, feel free to put it in the chat. And we will hope to answer all questions later on. Next slide, please, John. So just a brief introduction as to the topic for today, why emergency care. I want to set this scene by describing some of how the global landscape has evolved in the past decade. As you can see here on the left side of the screen, in 2019, the World Health Assembly adopted a resolution to help countries and support the insurance of timely care for the acutely ill and injured. It is estimated, as described here, that more than half of deaths in low and middle income countries result from conditions that could be treated with better pre-hospital and emergency care. The schematic on the right side is I really appreciate this schematic because it shows the continuum of care. It represents the onset of symptoms, kind of things that happen at the scene, things that happen immediately when the event happens. This emergency care systems framework is put together by the WHO, along with a package of technical resources and other supports to help countries across the globe to support developing their acute and emergency care systems. This is a larger effort across different INGOs in the past years, where the increasing awareness of the importance of acute and emergency care globally for all people is receiving increased investment and interest. There are toolkits that are available at the WHO for various aspects of this work, including workforce development. There's a ton of work going on across the globe, which brings us to our webinar today. Next slide, please. Where our goal here is to really describe the efforts across different programs across the GW institution and Children's National, as well as with our teams and our partners around the globe, to develop emergency and acute care systems. Our panelists today will showcase our efforts representing two distinct global regions, focusing on key concepts of partnership and innovation, leading to incredible impact, the value of advocacy, and different opportunities to get involved. These programs bridge across adult and pediatric worlds, and through these efforts, we are really proud to represent GW globally in our reach and scope. These are not programs and partnerships to deliver, specifically deliver care or treatment, but most of our programs and partnerships are capacity building programs to build systems around the world. Kicking us off today is Dr. Tania Ahluwalia, who's from Children's National. Next slide, please. She's the director of our global pediatrics programs for the Ronald Reagan Institute of Emergency Medicine. She's going to describe in more detail a large-scale program to build capacity for acute emergency care in India and a series of innovations relevant to that work and potentially relevant to other contexts as well. Over to you, Tania.
Thanks, Kate. All right, let's talk about emergency medicine in India. So India has a population of 1.44 billion, with a projected population of 1.7 billion in 2050. This is compared to the US projected population of 381 million in 2025. The country faces a burden of conditions requiring emergency care. This includes things like acute cardiac events, infectious diseases, and trauma. Tragically, more than 6 million deaths are recorded annually, with over 150,000 road traffic fatalities, making India the highest globally. These statistics highlight the pressing need for emergency care in India. Next slide, please. Emergency medicine was formally recognized as an independent specialty by the Medical Council of India in 2009. And since then, emergency medicine training programs have been initiated in public and private hospitals. Despite this, there's a critical need to train the emergency medicine workforce. India has only 196 government-sponsored training seats for emergency medicine, compared to the US, with less than 1/4 of India's population offering over 2,200 seats. The US offers over 11 times the number of emergency medicine training spots compared to India. This stark disparity highlights the critical gap in emergency medicine education and the need for sustainable and scalable initiatives, as well as capacity building efforts. To reach similar proportions, over 130,000 trained emergency physicians are needed in India today to provide adequate access to emergency care. Let's talk about how George Washington University has worked to build capacity in India. Next slide, please. The Ronald Reagan Institute of International Emergency Medicine at George Washington University has an institution-led partnership advancing emergency medicine in India since 2006. Through partnerships with 21 institutions across India, the Ronald Reagan Institute at GW has established a structured 3-year training program that has trained over 1,200 emergency medicine physicians, significantly enhancing emergency care capacity in India. During the COVID-19 pandemic, we transitioned from an in-person to virtual education, allowing flexibility and reach, and now we have a hybrid model combining both. The photo to the right is our faculty and recent graduates at a faculty development workshop in Delhi earlier this year. Next slide, please. Our training programs are designed to align with the realities of healthcare in India. Developing educational materials that are locally relevant is key. Our training integrates cases specific to Indian emergency departments, ensuring cultural sensitivity and adaptation to varying resources. This approach empowers trainees with practical solutions tailored to their context. Examples of this include cases such as dengue or multi-trauma from a scooter accident, or procedural skills such as using large bore IVs instead of intraosseous needles where equipment is limited. The photo to the right is one of our former residents and now faculty members who's developed a pediatric specific code card at his site. Next slide, please. Our hybrid learning model integrates in-person training with cutting-edge virtual tools. During our training sessions, trainees from different regions are able to connect and collaborate. Our interactive content includes simulation, telesimulations, remote procedural workshops, and even virtual escape rooms designed to prepare trainees for high-stakes clinical situations while ensuring engagement. The image to the right is our trainees participating in ASAP Telesim in a Box, an open access platform for medical education. Next slide, please. Simulation plays a vital role in emergency care training. We emphasize culturally and contextually tailored simulations to mirror local healthcare challenges. We adapt cases to match the local sites. For example, we say adrenaline instead of epinephrine. These simulations not only build skills, but also foster global collaboration through workshops and events. The image to the right is our trainees performing a live simulation for their final examinations with local faculty at their site and international faculty online. Next slide, please. With telesimulations, we leverage technology to overcome geographic barriers, bringing high-quality education to regions that need it most. This is an example of the virtual resuscitation room, where we've created cases to meet the needs of our learners, including procedural skills training. The image on the left shows a virtual resuscitation room with the patient, orders, monitor, and supplies. And the second image on the right is the residents practicing a lumbar puncture procedure. Next slide, please. We've also developed remote procedure workshops. So here's an example of a suturing workshop, which included didactics and then a live demonstration. And then our trainees were tasked with putting their skills to test in the emergency department. And on the right, the image shows 2 examples of their work. Next slide, please. We've also developed and designed case-based virtual escape rooms, similar to an in-person escape room where you're using puzzles and clues to try and escape. This one is on organophosphate toxicity, which is common in India, and each puzzle and clue is linked to a learning objective. In summary, our innovative, locally tailored approaches are advancing emergency medicine in India and building capacity. Back to you, Kate.
Thanks so much, Tania. And John, can you advance to the next slide, please? I really appreciate that overview of the innovative educational partnerships and the programs and the different tools that we're using to reach more people and really achieve scale and scope to try to build capacity through systems development. So next up in our speaker lineup is Dr. Jinesh. And Dr. Jinesh, if you could please turn your camera back on. We are going to turn it over to you. He is one of our longtime program partners, an emergency medicine doctor joining us from Kannur, India, which is in the southern state of Kerala, where we've had the opportunity and pleasure of working with him and his colleagues in a group for the past decade and a half building emergency care systems. He is going to describe here a lot of the capacity building efforts that go beyond the educational intervention towards really building the system, increasing capacity, and evidence of how this is working to really save lives. So Dr. Jinesh, thank you for joining, and over to you.
Thank you, Kate, for the opportunity. Good evening, all. It's around midnight here. So that's why I said good evening. Myself, Dr. Jinesh, heading the Department of Emergency Medicine and Aster, Kannur, which is the southernmost state of Kerala in India. Next slide. So the content of this presentation would be a little bit about the history of the emergency medicine programs, the community programs that the Aster Emergency Network has taken up, the systems of care, and a little bit about the disaster preparedness and resilience. Thank you. Next slide, please. So there was a time when emergency medicine in India was staffed by the most junior-most physicians with little or no training at all in acute care, and the specialists made decisions for the patients in the emergency department. And the triage was done usually at the bedside with multiple issues with the patient flow. There were no protocols, no ATLS protocols, no ACLS protocols, nothing. And there was absolutely no training for the emergency nurses as well. And there was no emergency medicine training nationally in a formal study. No structured programs at all. Next slide, please. So the partnership, actually, the most wonderful partnership between institutions in India and the George Washington University started in 2007 with the partners being Indian Institute of Emergency Medicine, Malabar Institute of Medical Sciences, now known as Aster MIMS. There are other institutions like Care Institute of Medical Sciences, Max Healthcare, etc. And this partnership started off with a 2-year postgraduate program, which is known as FEM, back in 2007. And later it was converted into a 3-year program starting from 2009 onwards. And I remember myself joining in 2012 for the program in Calicut. Now, all these 7 Aster institutes inside Kerala and 2 outside Kerala are running the the emergency medicine program in collaboration with the George Washington University. There are hundreds of graduates from our institutions who are working all around the world. And we are the leading group in training emergency medicine across India. Next slide, please. So one thing that I would like to talk about most is the community-based program. In fact, there is no group of people that we have not involved in the community-based program, whether it be students, whether it be the police force, the fire and security people, the airport authorities, the army, the local public, the bus drivers, the ambulance drivers, name anything. It's not a day that passes without some sort of training happening for all, not just the healthcare workers. In addition to that, we have included the healthcare workers working in the remote areas in our program so that that increases the patient outcomes. Even in the local hospitals, we train the doctors, the junior doctors, in the emergency care so that they can do something at the ground level itself. And we have also increased the accessibility of the people to emergency care by training the remote care hospitals. And the trainings are basically tailor-made to address the specific needs. For example, if you're training a nurse in the periphery, they are trained to do the necessary things like life-saving things, etc. And this also fosters a lot of collaboration with the outside agencies, including the police force, including the ambulance drivers, including the fire and security people. And this creates a lot of capacity building for the local healthcare systems as well. So there are many programs that are directly taken up by the Aster Institutes, like the Be First programs, which is an initiative to make lasting impact on the public health and safety. There's another program like GCCA 2022, which is a pioneering first aid and trauma awareness program. There are rapid response team that Aster has trained. There are life-saving initiatives, and a lot of BLS trainings are happening throughout the state by in our auspice. And there are other community outreach programs as well for the school students, for the other healthcare professionals and other people. In fact, we were partners of the world record-winning mass CPR training, hands-only CPR training, which happened in Kochi in 2019 on December 4th. The next slide, please. So the basic aim is to increase awareness among the public regarding the life-saving skills and the importance of CPR in saving lives, to train a large number of people in CPR techniques, and also to create awareness about the importance of emergency medicine care, and also to enhance the resilience during disasters and the mass casualty, and for better resource allocations. Next slide, please. So the programs that are taken up are the CPR training for medical professionals, including doctors and nurses. In-hospital training and out-of-hospital training happens on a daily basis. There are training programs for the public in first aid, trauma management, and large support. The picture that you see here is actually a part of a road show which happened throughout Kerala as a part of World Trauma Day. And we kept traveling down the road, training people in the bus stands, in the auto rickshaw booths, etc. And all over Kerala, this training happened. It was just ahead of the emergency medicine conference that we had under the auspice of Aster Emergency Network. The enormous training of the public has happened over the past few years. All this has happened only because of the collaboration that we have with the GW. And now we have started training medical students and nurses across the nation, and also in training the health professionals, the fire and security people, the police, other security officials, airport staff, etc., in disaster management, in the preparedness, as well as in capacity building. Next slide, please. So we make sure that there is an active participation at the community level. There are social clubs, there are school. There is something called student police force in Kerala. There is a national service scheme in various institutions, educational institutions. We make sure that we involve all these people in our community and social activities. And we take up a leadership role in the disaster response industry, not just in giving medical care, but also in rescue activities as well. There are other school and college-based training initiatives in both life-saving skills and disaster response. The pictures that you see here are the first one is a training program for the school students, and the second one is for the CAS of the security force in the airport in Kannur. Next slide, please. So the pre-hospital system of care. This is the first batch of EMT trainees training that happened in Calicut Aster MIMS. Though there is no centralized system for our ambulances, we make sure that the ambulance facilities and the personnel are trained well, so that much more can be done for the patients. And also we have involved the ambulance people, the pre-hospital care system in stroke and acute coronary system transport and management. Next slide, please. Inside the hospital, the system of care, we have established recognized or accredited emergency department. Almost all of our emergency departments are NABH accredited, with comprehensive trauma management team, with stroke protocols, coordinated services, and also and we take a leadership in development of all the protocols that happen inside the hospital. So emergency medicine department is one core group that builds up protocols for the hospitals to work on. Next slide, please. So we have emergency department, which is NABH accredited. The NABH is the National Accreditation Board for Hospitals and Healthcare Providers. So, and regular audits and quality improvement programs, not just for the NABH accreditation, but on a daily basis to improve the quality of service that we give are undertaken in our emergency departments. Next slide, please. And of course, we cannot move away from this. Calicut MIMS and other institutions have started with the telemedicine programs, and also we have a system with which is known as RRR, Rapid Response Team, which has AA-equipped and AA-equipped ambulances to transport patients with a stroke. And we almost all the institutions maintain electronic health records for further reference and audits. Next slide, please. So these are few examples of the disaster preparedness and resilience that we have. All the hospitals under our institute has emergency response plans, and we lead almost all the response teams in all the institutes. There's an incident command system, and we have particular mass casualty triage and treatment protocols for all the hospital. And above that, we have few teams like the Aster volunteer network, who aids, which are not actually staff or employees of the group, but they are common public who are enrolled into the Aster volunteer network, who render a lot of service to the community in the times of disaster, not just for treatment of people, but also take a big role in the transfer of patients and taking care of the other patients. Next slide, please. So in disaster response, it's not just medical assistance that we are taking care of. We are also involved in the search and rescue operations in collaboration with the other forces like the police force, the fire and security people. The picture that you see on the top is one of our specialists, Dr. Lavina from Calicut, who is hanging down a rope during the recent landslide that happened in Wayanad. We also take part in relief material distribution, assistance in planning and preparation, and also we are a part of disaster response training and capacity building all across the state. Next slide, please. The success story happens with assistance and partnership with various organizations like the National Disaster Management Authority, the State Disaster Management Authority, and a few non-governmental organizations and public sector organizations like the police, the fire and security people, and the other government hospitals and other things. Next slide, please. Here are a few responses, few success stories that we have had over the past few years. There are 5 of them. We'll go one by one and just give a brief idea of what has happened. The first one was an evacuation in our flagship hospital, which is Aster Medcity in Kochi, who had to evacuate around 100 people. Next slide, please. We'll go to the slides directly. So this is a waterfront flagship hospital. You can see how beautiful it is. But during the floods in 2018, the whole area was flooded. More than a floor, the basement all went underwater, and we had to evacuate around 100 people, including 350 patients and other doctors, staff, nurses, and other public also. And absolutely, we had 0 casualties during that evacuation. It was a well-planned one. All the patients were shifted safely, accompanied by the medical professional to various hospitals whoever we could manage the patients and save all of them. Next slide, please. Another one was the most well-recognized field hospitals, which was created in the span of just 5 days during the COVID era, where we were not able to accommodate people inside the hospital, where we needed more beds, and people were running here and there for getting beds. It was done in just 5 days, and we created around 30 beds with 20 bedded beds with BiPAP facility, non-invasive ventilation, HFNC, and 10 with ventilators. The next slide, please. So again, an event happened in Calicut, where 47 people were taken to MIMS Calicut of the more than 120 20 injured people who were taken to various other hospitals as well because of a flight crash. And all these patients were properly managed in the hospital because of the clear-cut idea and because of the trainings that we had. We had already conducted a mass drill or a mock drill in the same place where the actual accident had happened a few years back. Next slide, please. So these are two pictures I am showing about the Wayanad landslide response. So the first picture that you'll see the Google photos of what happened the day prior to the landslide and the day after that. A lot of people were involved in this. Many townships were completely washed out. Next slide, please. Next slide, please. Okay, yeah. So there were total of around, no, the previous one itself, sorry. Around 479 people were treated in Wayanad, in our institution in Wayanad, where the ED alone received around 222 patients. Around 32 patients required surgeries, and none of them succumbed to their injuries. All were saved. Imagine that happened in over a span of few days. As 3 patients were brought to the Wayanad Mupens Medical College, which is under Aster. That is another success story of our disaster management and resilience. The next slide, please. So this has happened in my own institute. There was a blast in the nearby district with around more than 200 people injured, of which we received around 35 minutes in a span of just 30 minutes by around 2 a.m. in the morning when the hospital was completely there, like the number of doctors and nurses were at the minimum. And early morning, we could manage all the 35 patients in a span of just maybe 1 hour or 2 hours. And by morning, when the press people came to record those things, there was not even a single patient in the emergency medicine department. All were properly taken care of in the ICUs, in the wards, and also a few people had to be transported to Calicut for particular needs. Next slide, please. So to conclude, all this happened because of a wonderful fruitful collaboration between the George Washington University as well as the Aster MIMS Kannur. Not just Aster MIMS, there are other institutions as well. But we could become the leaders in emergency medicine care in the state of Kerala, now spreading its wings throughout India because of this fruitful collaboration. And all this happened because there was a system development, a proper planning of the emergency department, a proper protocolized methodology, and with constant teaching and training, not just for the residents inside the hospital, not just for the doctors inside the hospital, the nurse, not just the nurses, for the public, for every person around, for the school students, for the college students, all those groups. Continuous teaching and training is happening across the state, and that has helped us in developing strategies for better patient care and for better outcome. And all this results in thousands and thousands of lives saved. I thank everyone for this wonderful opportunity. Next slide, please. This is my favorite slide again. So those are my mentors. You can see Kate in the middle with a small kid, and that's Dr. Venugopal, whom I always consider as my mentor in my personal life as well as in my professional life. Thank you all.
Next slide, John, please. All right, next slide, please. All right, my name is Camilo Gutierrez. I'm a pediatric emergency physician, and I am the director of global health programs for the Division of Emergency Medicine at Children's National Hospital here in Washington, D.C. And so to put things in frame, the first slide Kate presented regarding the framework of emergency medicine, it's something similar we would imagine pediatric emergency medicine in the world. Emergency medicine turned 50 years old a few years ago. Pediatric emergency medicine, it's lagging behind in many regions in the world in the same framework. However, over the last decade or so, more regions have recognized peds emergency medicine and the importance of understanding how the treatment of children in critical care or trauma injuries is important. Next slide, please, John. today, some of us have worked our careers trying to enhance and help develop these pediatric emergency medicine training programs. And today I'm very happy to have Adriana Yock, Dr. Corrales, joining us from Costa Rica, where she's originally. Adriana and I have worked over 10 years in pediatric emergency medicine. She is a pediatric emergency physician trained in Australia and the only one currently in Costa Rica. She runs the emergency department at the Children's National Hospital there. And she's occupied leadership roles at the international level in the International Federation of Emergency Medicine. She's a founder and board member of the Latin American Pediatric Emergency Medicine Society, and she's the co-chair of the Regional Research Network. And she's going to talk to us about development of PEM in Latin America. Adriana, so I'll let you go on with this. Next slide, John, please. Thank you.
Well, thank you very much, Camilo, for the introduction. So, pediatric emergency medicine, as Camilo mentioned before, is quite new. I mean, the last maybe 12 years is the amount of time that we have recognition of this specialty here in our countries. So as you can see here, Latin America is we have around 33 countries and the population around 6 million people. We have one of the highest levels of income inequality in the world. And also, if you divide this in geopolitical areas, we have Central America, the Caribbean, and the South Cone. That is how it's mentioned as a geopolitical region. We have many languages. The predominant languages is Spanish and Portuguese, but we have some of the Caribbean islands, for example, that their main languages is French, English, Dutch, and Papiamento. That is a barrier to get everybody in Latin America together because of a barrier of a language. And also the communication between Europe and North America, and also the barrier with English is something that is important to take into account into this pediatric emergency medicine development. Next, please. So this slide is just to give you an overview that a big journey always begins with the smallest steps. Next slide, please. And when we talk about when did pediatric emergency medicine was recognized for the first time in Latin America, it was actually in Mexico in 2007, when one of the pediatricians there went to the United States to do his pediatric emergency medicine fellowship. And then it follows Peru, Costa Rica, after I arrived from Melbourne, Australia, and Uruguay, Argentina, and Paraguay, and recognized the specialty after they knew they had to develop a fellowship. They recognized the importance of this specialty, and it was around these years that we started with hospitals with pediatric emergency medicine doctors in the South Cone. We also had Brazil in 2014 and Dominican Republic in 2018 that recognized the specialty as so in the Ministry of Health and other instances. Next slide. So in terms of pediatric emergency fellowship, it hasn't been an easy road. In some of the countries, they had support from people that already had fellowships in other countries, especially United States, Canada, Europe, and Australia. And it hasn't been an easy road. Next slide. Since 2007, 2006, that the first fellowship was established. And from today, we have now 23 fellowships. Next slide. We have now 4 in Mexico. 2 of them are located in the main children's hospital in Ciudad de Mexico. Then we have 5 in Argentina. Well, actually, Argentina was one of the countries that had their first fellowship in South Cone. We have 3 in Paraguay, 2 in Peru, 6 in Brazil, 1 in Dominican Republic, 1 in Uruguay, and 1 in Ecuador. All of the fellowships are in university hospitals and also in the main children's hospitals of their countries. Next slide. This is kind of a table that was published in Current Pediatrics about the story and history of our pediatric emergency medicine development in Central America and the Caribbean and South America. Just to remind you that in terms of how the fellowship was established, we have to get the basis from other programs already done. Next slide, please. an iconic thing that happened in 2016 was the establishment of the first pediatric emergency medicine Latin American society. Next slide. Well, next to get a picture in the slide. Thank you. And the next, please. So in 2016 in Uruguay, in one of their meetings in the Congress of Pediatric Emergency Medicine in Uruguay, it was established our society. This was very important because we kind of put us together. Before the establishment of the society, we were working all in different pathways, and I think the society gave us something that we put us together, and we start working together in the development of this work. Also, RIDEPLA, the Research Network of Latin American Pediatric Emergency Medicine, actually was established in 2011, 2012, in one of the sabbatical journeys of Nathan Cooperman. You probably, some of you know him. He's a pediatric emergency medicine. He was working in UC Davis. I think he's now working at the Washington Children's Hospital. Camilo can later tell me if that is true. And he went into a sabbatical in 2011 because he knew that to increase the development of pediatric emergency medicine, we also need to get research done. And it wasn't until 2017 that RIDEPLA, that is the name of the research network, became part of SLEPE as the research group of RIDEPLA and of SLEPE, sorry. And that is when we start doing a little bit of more research and also publications. Next slide, please. We have done some alliances with the society, with a lot of associations and societies in Latin America, especially coming from pediatric associations and emergency medicine associations, and that helped us to give us a little bit of visibility around the area. Next slide. In our society, we have now more than 300 members, and that 300 members are coming from 14 countries. We have developed a lot of working groups. A lot of them are more active than others, but we have, for example, sedation, analgesia, a toxicology group, a safety and quality group, ultrasound group, disaster, transport group. Some of these groups have helped develop also research projects and also have helped to develop online courses that keep giving a little bit of funding to the society. Next slide. So we have now in our society since 2016 until now, we have at the moment 6 online courses that we have developed with some of the members and the working groups of SLEPE. I have to say that they are good quality courses, and especially because most of the offer that is around, in the internet is English-based courses. And we thought of the need of having Spanish courses that were think for our population, that we have a lot of inequality and also low resource countries. And so we have developed these courses that have been have ongoing editions every year. Next slide. So as Camilo mentioned, I co-chair the RIDEPLA network with Viviana Pavlicek. We have a steering committee. We have principal investigators, site investigators. Next slide. A lot of the site investigators are coming from the main countries or the biggest countries in Latin America, like Argentina, Brazil, Chile, Mexico, Uruguay, Paraguay. All those site investigators work in hospitals that they have admissions in ED from 5,000 to 120,000 admissions per year. So that gives us a possible pediatric population of almost 1 million children per year. So that is an amazing accomplishment, to do a little bit of research and also to kind of help us compare our population with the big countries like United States and Canada and other research networks. Next slide. So just, I don't know if you know that we have the Pediatric Emergency Medicine Research Network, that is a world pediatric emergency research network. To becoming part of this World Research Network, as a region, we need to publish a peer review paper, and we were able to do that in 2019. That is something that was very important for us because it gave us an option to also participate and collaborate with other studies around the globe. So for now, we have a lot of publications since 2019. Next slide. We have some of them that explains a little bit how the development of our network was done. Next slide. And also, as you can see here, the PERN, that is the Pediatric Emergency Research Network, has networks from 6 of the 8 World Health Organization regions. So that is important because we collaborate in studies with Canada, United States, Europe, Australia, and New Zealand, and Spain, and that it gives us more visibility in terms of evidence-based information of what we are doing in our pediatric emergency medicine departments. Next slide. We also did an alliance with the CEUP, that is the Pediatric Emergency Society of Spain. And we have now this journal that together we publish this journal every 3 months. This gives us an opportunity to not only have publications in our language, that is Spanish, but also give us a little bit of visibility of what we are doing. And also, if people want to publish these articles in English, they can do it as well. But this is something that was very important. We have our first edition in 2022, and we have every 3 months a publication of this journal that is very important for us. Next slide. So there are some challenges in Latin America, and as I said before, we have a lot of inequality in terms of education, health system, how urban areas are very different to rural areas. Some countries they are low resource countries, some others are a little bit high income, and that gives us a little bit of challenges of how we can get everybody involved in developing and, of course, making pediatric emergency medicine grow around our region. We also have barriers, like, for example, we have a lack of research culture. We don't have in most of the, I will say in all countries, we don't have like research protected time during our work in the hospitals that we are, especially because most of them are public hospitals. So, I mean, there are a lot of challenges, barriers. We have a lot of enthusiastic people that want to work together, and that is something that has kept SLEPE together and also making people wanting to be with us and working with us to help this pediatric emergency medicine develop in our region. Next slide. I think that for the future, we want to have alliances with other groups, like, for example, the Pediatric Emergency Medicine Special Interest Group of IFEM. That is, most of the members are English-based members, and we want to have these alliances with other people and also exchange of knowledge and information so we can, people think that people will want to know that they're not alone, that pediatric emergency medicine is something that is very important, and that is a need to have pediatricians that are trained in emergency medicine, in pediatric emergency medicine, in the hospitals treating children. Next slide. Thank you. You're mute, Camilo.
I think we would know this for now, right? I just want to wrap up what Adriana said. Like I said, emergency medicine has evolved over the last 50 years. Now there are over 100 countries, and every year there are 2 or 3 more countries that recognize and have training programs in emergency medicine. In peds emergency medicine, we lag, but we're moving the needle forward with efforts like the one like Adriana and the other people in Latin America are doing. And globally, we're working with other regions to help understand and develop the importance of pediatric emergency care. So hopefully this is an example of how working together with your colleagues in different countries will help develop the understanding and move the needle towards the evolution and the progression of peds emergency medicine. With now, I'm going to just put Dr. Douglas back, and we can finish the next few minutes of this webinar.
Yeah, thanks, everybody. And John, if you want to just take the slides down, we're going to have a couple of minutes for questions, and there have been some great questions in the chat. So Dr. Jinesh and Dr. Ahluwalia, if you are able to come back on video and join us, that would be fabulous. And thanks to everybody. I have my own comments and questions, but I'm going to try to stick to the chat and see how we go. Specifically, to start us out, there are a couple of questions in and around training and encouraging participation of medical students and community-based training programs and expansion of community-based training programs to various settings and trying to engage people. So I wonder, Jinesh and then Tania, if you could maybe respond to some of these questions in and around how to both expand training, including different levels of non-physician providers, and then also in and around training physician providers or clinician providers who are not from the traditional field of emergency medicine, if you will. Maybe Tania, you want to start us out, and then Jinesh, you can jump in next.
Yeah, sure. I know Dr. Ascari asked a question about diversifying training opportunities, so we can start with that. I definitely agree with the idea of diversifying these training opportunities across specialties to address gaps in EM physician training while we're waiting for specific EM training programs to scale up. In India, they have MBBS programs, which are similar to the MD programs. And trainees may receive some exposure to emergency medicine during their rotations, particularly during internships in the casualty department. But this training is often limited in scope. And then subspecialty fellowships like pediatric emergency medicine are still in their infancy in India and other places like you heard from our other speakers. So expanding training options to general practitioners could play a significant role in bridging these gaps. There are some training programs like BEC, Basic Emergency Care, or ATLS, or PALS, Pediatric Advanced Life Support, which could help support and enhance capacity to build acute care. And then integrating emergency-focused curricula into the subspecialty pathways could help create a more versatile workforce. I think those are the main points in terms of diversification, and I will pass it over to Dr. Jinesh.
I'm going to jump in for one quick second. Just to add on to that, one of the other things is one of our partnership options that we've used, as opposed to just having the full-time training programs, is other kind of non-full-time or in-service training programs that are for building skills and knowledge, but not requiring a full-time commitment. And so there's lots of different ways to diversify, but that does build also onto the points that Jinesh has made in and around training of other, community members, paramedics, medical students, and all of kind of how that bridges out and beyond just the kind of clinician training programs that we're talking about. So Jinesh, over to you.
Thank you, Kate. The question that's put forward for me is EMS system under the Ministry of Health, I suppose, or other ministries? I think he's talking about the course that we are running, the EMS course that Aster is running. It's basically under the Aster Academy itself, MIMS Academy, which has put forward this course. It's not under the any ministry. It's an institutional program under the Aster MIMS Academy. Then whether it's voluntary or it's purely voluntary, right? There is nobody's forcing anyone to get trained. But every day or almost every week we have training programs for the nurses and the EMS. They have a particular course itself along with the working inside in the department. So that's all. I don't know what was meant by it's the CBP training as part of Aster, whether it's voluntary or obligatory.
Yeah, I think I can also add in that this idea of outreach to the community and community training is almost like it's like a mission component of what is being done through the Aster network. So it's not it's part of the clinician's job sort of, but really it's part of the mission to build capacity through training. And so there's a training at the community level, training at the kind of school level, training that expands, as Jinesh said in his presentation, training that reaches the scope of the world record for the single day number of people trained in hands-only CPR. And all of this is really kind of motivated by the Aster network and the desire to build capacity outside of the hospital walls so that community members can respond appropriately in the time period when something starts, whether it's a traumatic event or a cardiac event or what have you. I'm curious also to expand that to Dr. Adriana and Dr. Camilo in and around this question of medical student training, because I think this is a space also where there's growth. I'm curious what your experience has been in terms of building medical student exposure and experience in emergency medicine to then kind of serve as a pathway to increase the number of people choosing this as a specialty.
Do you want to speak, Camilo, or should I go first?
Go ahead, and then I'll.
Yeah, I mean, still we are having difficulties in incorporate pediatric emergency medicine training in the medical schools in Costa Rica, at least in my experience. We do have, since I came back from Australia and started in our hospital, I am now a faculty in the emergency medicine and pediatric postgraduate teaching. And we do have a specific course for pediatric emergency medicine. And I think since then, we are gaining a little bit more people wanting to have, or at least work our children's hospital from EM. That is a win. And also pediatricians that want to do as well pediatric emergency medicine. The problem, at least in my country and in my experience, is that we don't have the fellowship here. So, I mean, it's expensive to go overseas. You need to find a place where they will have you, they will pay you, because we don't have, you know, as a middle income country, we don't have money from the state to give to people to go and do the training overseas. So that is something that is the same in most of the countries in Latin America where they don't have fellowships. And that is something that I think with the SLEPE since 2016, it's been a little bit more people wanting to open fellowships in their countries, and that is something that we are improving every year.
Yeah, Dr. Douglas, I think with regards to medical students, it's a little bit harder at this point in time. I think, you know, the rate-limited steps, like, for example, most countries would need a specific number of trained PEM providers to start a fellowship, right? In Colombia, we also are training our own peds emergency medicine folks to be able to get recognition by the government to start a fellowship. So mostly we're focusing on people that already are doing some kind of acute care, mostly pediatricians. In the region, right? In other countries are more EM physicians are doing PEM. In Latin America, it's mostly pediatricians. So we've established our own curriculum for training, which is now a unified curriculum for the entire region. It's a 2-year program after being a pediatrician, and we're hoping that way we can expand on that. Having said that, there are opportunities. Again, the language is a key thing, right? And 2, probably mostly for either peds residents or emergency medicine residents that go. There are some programs that send routinely EM residents to Paraguay, for example, to do a month rotation on peds emergency medicine there. And we do that as well in different countries. So that would be an opportunity. I think there's another question, Kate. I think we have just a few minutes left, and it was regarding, and Adriana, this is for you too. Is there any national level data regarding the relationship between establishing SLEPE and outcomes? And I think there's some, like, we understand is like, you know, we started a society, we're training PEM pediatricians. Do we have any outcomes to show how this affects care of children?
Yeah, we haven't got data on specifically on how that improved. We do know that after SLEPE was established, a lot of countries start opening, and in countries that already have one fellowship, it started opening more fellowships. and that at the end will increase the amount of pediatric emergency medicine physicians. It's been difficult, because it's asking about Cuba, about some countries, getting access to some countries and getting access to the doctors that work in those countries, specifically in the emergency departments of the Children's Hospital. For example, Cuba is an example, Nicaragua is another example, El Salvador. It's been very hard to get communication with them. But I guess that is a job and a work that we in SLEP are trying to get into, trying to get contacts and see if we can get more people involved, because we do want to have all the countries in Latin America in SLEP, and that will give you more representation, not only for research, but also, you know, for how the information will get into all the hospitals and people and pediatricians working in those countries.
And just to finish the last comment about that, Kate, is that, but however, we don't have that outcome, but we have shared guidelines. So we know how different countries treat sepsis. We know how we do pre-hospital pediatric transport. So we're standardizing the care of children across the border. And it's just a matter, inevitably, this is going to trickle down to improve the care of critically ill and injured kids in the region.
Yeah, thanks for that to both of you. And thanks for the question, Dr. Ascari, as well, talking about outcomes, because I think it's aspirational and I think that everybody's working in that direction. And I think that working to improve the research capabilities, the networks, the education and training opportunities, all of these things are working towards that ultimate goal of improved patient care and improved patient outcomes across the pediatric and adult patient communities. So that's what the goals are, and that's what I think everybody's working to get to. So more to follow there. I think we're getting closer, and the amazing work and the partnerships that you described, Adriana, and partnerships across the world are working towards this. Just in closing, thanks to everybody for joining. Many thanks to the panelists. I think this was an amazing presentation, and it was a real showcase of the goals that we set out, which was partnership, innovation, impact, advocacy, and then opportunity. John, if you could just pull up our last slide about the next webinar. I will say in closing a couple of things. I'm going to re-put up the Global Clinical Care Alliance website into the chat. And so keep in touch with this group. And we are always, we can make connections to specific projects and partnerships that people are working on and see how we can build opportunities to continue to find ways to work together and ways to leverage the work that's already being done. I'm pleased to announce that we will be having our next webinar as part of this series in March of 2025. Led by Dr. Lalit Narayan and Gavin Trong, focusing on the topic of learning locally, thinking globally, educational opportunities for domestic global health training here at GW. So in the meantime, stay in touch. Thanks to everybody for joining. Thanks to the panelists for an incredible presentation, and everybody stay safe. Take care. Bye-bye.